Have you ever found yourself rubbing your elbow, maybe after a long phone call? Or, woken up with your little finger and ring finger tingling, feeling distinctly asleep? That peculiar electric shock feeling you get when you bump your funny bone. Well, that's not just a childhood thing, is it? That funny bone sensation is actually related to your ulnar nerve. And sometimes those feelings can be a telltale sign of something a bit more persistent. Cubital tunnel syndrome. It's actually the second most common nerve compression problem in the arm, and believe me, it can be far from funny when it persists. So today we're going to really unpack this often misunderstood condition. We'll explore exactly why it happens, who's most at risk, and crucially, what practical steps you can take if you're experiencing it. Welcome to the Deep Dive, the show where we cut through the noise, sift through the research, and pull out the most important insights from a whole stack of sources, all to make you well-informed fast. And joining me today, guiding us through this fascinating topic with his really unparalleled expertise, is Professor Mohammed Imam. Professor Imam is a highly esteemed consultant orthopedic surgeon, subspecializing in upper limb surgery and complex trauma reconstruction. His deep knowledge of the elbow, shoulder, and wrist brings, well, invaluable depth to understanding conditions just like cubital tunnel syndrome. So, Professor, just to start us off, could you maybe define cubital tunnel syndrome for us in simple terms, and perhaps paint a picture of why the elbow, of all places, is such a vulnerable spot for this kind of nerve compression?
Of course. So cubital tunnel syndrome, or CUTS as we often call it, is essentially what happens when the ulnar nerve, that's one of the main nerves running down your arm, gets squeezed or irritated. This happens as it passes through a tight passageway on the inside of your elbow, a place called the cubital tunnel. Now,
Right.
the reason it's so vulnerable right there is because unlike many other nerves, which are nicely cushioned by muscle and fat, the ulnar nerve at your elbow lies very close to the surface. It's right behind that bony bump we all know as the funny bone, technically the medial epicondyle. Because it's so superficial, it has very little natural padding, if you like. This makes it highly susceptible to pressure or stretching, particularly when you bend your elbow.
That makes perfect sense, almost like an exposed wire running around a corner. And given how common you said this is, what's one key symptom, maybe one distinct feeling that should really flag this condition for someone who's experiencing discomfort?
I'd say the most consistent and often the most diagnostic symptom to really pay attention to is persistent pins and needles, or numbness. Paresthesia, we call it. And crucially, this sensation typically affects your small finger and the outer half of your ring finger, the side nearer the small finger. It's quite distinct from, say, carpal tunnel syndrome, which involves different fingers altogether. You'll often find this tingling or numbness gets worse with prolonged elbow bending. Think about holding a phone to your ear for ages, or perhaps sleeping with your arm bent tightly under you. So if you're getting that specific finger numbness, especially when your elbow is flexed, that's a really strong signal. The ulnar nerve is likely being irritated at the elbow.
Right, that pattern is key. And before we dive deeper, what's the most common misconception people tend to have about managing cubital tunnel syndrome once they start noticing those symptoms? Because I imagine people might jump to conclusions.
Yes, you've hit on a really crucial point there. A very widespread misconception is that if you experience these symptoms, surgery is, the immediate and often the only solution. But actually, in reality, for the vast majority of mild to moderate cases, we initially recommend conservative, non-surgical approaches. These usually include simple activity modifications, avoiding certain postures, and some very specific exercises. Surgical intervention is typically only considered if these conservative methods have been tried consistently, maybe for 3 months or more, and haven't provided enough relief. Or, of course, if there are clear signs of more severe nerve compression, like noticeable muscle weakness or wasting. So early intervention, which is often non-surgical, is truly key to a good outcome.
That's a really important distinction to make right from the start, thank you. Let's delve deeper then into the intricate anatomy behind this funny bone feeling and exactly how the ulnar nerve gets into trouble. You mentioned it's one of the main nerves. Can you walk us through its entire journey, maybe from its origins, up in the neck, all the way down to the hand, and really highlight what makes its pathway around the elbow so uniquely vulnerable?
Certainly. Understanding its path really does clarify the problem. You see, the ulnar nerve begins quite high up in your neck and shoulder area. It actually originates from a complex network of nerves we call the brachial plexus. You can think of the brachial plexus as the main sort of electrical junction box for your entire arm and hand. Specifically, the ulnar nerve gets its signals from the C8 and T1 nerve roots. That's essentially where these nerves branch out from your spinal cord in the lower neck. Now, from this origin, it travels down the arm. For most of its journey in the upper arm, it's actually quite well protected. It runs alongside the main artery, generally on the back, inner side of your arm. However, about 8 centimeters, that's roughly 3 inches above your elbow joint, it encounters a fibrous band known as the arcade of Struthers. Now, this band isn't in everyone, but it's present in about 70% of people, and for some, it can be a sneaky initial point of compression before the nerve even gets near the elbow proper.
Interesting. I hadn't heard of that arcade before.
Yes, it's one potential spot. After passing through, or sometimes under this arcade, the nerve continues its journey downwards. Then it takes quite a sharp turn as it passes behind that prominent bony bump on the inside of your elbow, the medial epicondyle. This is the exact moment it enters what we call the cubital tunnel. It's a very tight, quite confined space. Once it successfully navigates this tunnel, it immediately dives deep into your forearm, specifically passing between the two starting points, or heads, of a muscle called the flexor carpi ulnaris, we'll often call it FCU. It then continues deeper still, protected between the FCU and another muscle called the flexor digitorum profundus. Finally, as it gets closer to your wrist, it becomes more superficial again, passing over a key ligament there before branching out into the hand, where it provides sensation and muscle control to specific areas. But it's really that exposed superficial course right at the elbow, just behind the medial epicondyle, that makes it so susceptible to everyday pressure and stretching.
So it really is the architecture of this cubital tunnel itself that sets the stage for potential trouble. Could you describe the key components of this tunnel of muscle, ligament, and bone a bit more? What exactly forms its roof, its floor, and its walls?
Yes, absolutely. Imagine the cubital tunnel as a very precise, somewhat rigid passageway, a bit like a narrow conduit for an electrical cable. Its roof, the top part, is primarily formed by a strong fibrous sheet called the FCU fascia that covers the flexor carpi ulnaris muscle, and a specific thickening within this fascia known as Osborne's ligament. This ligament stretches directly from the medial epicondyle, your funny bone, across to the olecranon, which is the bony tip of your elbow.
Okay, so that's the roof.
Exactly. Then the floor of this tunnel, so what's underneath the nerve, is made up of 2 crucial bands of the medial collateral ligament, or MCL. Specifically the posterior oblique and transverse bands, plus the elbow joint capsule itself. And then, forming the sturdy walls of this conduit, you have the medial epicondyle on one side and the olecranon bone on the other. This very specific, tight, and somewhat unyielding structure, while it does offer some protection, also makes the nerve highly vulnerable to compression if any of these surrounding parts change shape, or if the pressure inside this already confined space increases for any reason.
That paints a very clear picture of just how tight a squeeze it really is in there. So how exactly does this anatomy lead to the actual compression? What's the specific mechanism that causes that familiar funny bone electric shock feeling, especially when we bend our elbow?
This is where it gets truly interesting from a mechanical perspective. The mechanism of compression is quite dynamic. It changes with movement. When you flex your elbow, say, bending it beyond 90 degrees, like when you're holding a phone to your ear or maybe reading in bed with your elbow propped up, the cubital tunnel actually narrows quite significantly. This narrowing directly increases the pressure on the ulnar nerve sitting inside. At the same time, Osborne's fascia, which, as we said, forms part of the tunnel's roof, becomes taut and tightens across the nerve like a strap tightening. Furthermore, the medial collateral ligament, forming part of the floor, can actually bulge inward slightly into the tunnel, reducing the available space even more. This effectively flattens the tunnel from a more rounded shape into more of an ellipse, further squashing the nerve. That funny bone sensation is precisely the result of this acute irritation and stretching, or compression, of the ulnar nerve due to this dynamic change during elbow flexion. It's a direct mechanical reaction to a very normal movement.
And it's not just that specific spot within the tunnel itself, is it? The sources mention several other potential sites of entrapment along the nerve's path. Could you elaborate on where else the ulnar nerve is particularly vulnerable to compression, both perhaps closer to the shoulder and then around the elbow itself?
You're absolutely right. While the cubital tunnel is the most common and well-known site, the ulnar nerve can certainly face trouble at various points along its quite long journey. Beyond the tunnel itself, a very frequent secondary site of compression is actually where the nerve enters the forearm, specifically between the 2 heads of that flexor carpi ulnaris muscle, the FCU, or its aponeurosis, which is a strong fibrous sheet covering it. This is a common bottleneck area just distal to the elbow.
Okay, just after the tunnel.
Exactly. Then going more proximally, so closer back up towards the shoulder, we mentioned the arcade of Struthers earlier. That myofascial band, about 3 inches above the elbow, can be a surprising compression point for some individuals. Other, less common but still significant proximal sites can include a thickening in the medial intermuscular septum, that's a fibrous partition separating muscle groups in the upper arm. And sometimes, in individuals with very developed muscles, perhaps bodybuilders, an enlarged or hypertrophied medial head of the triceps muscle can also impinge on the nerve path up there. Right. Around the elbow joint itself, compression can also arise from underlying structural issues. For example, a valgus deformity, where the elbow is angled outward more than usual, sometimes called knock elbow, can cause chronic stretching and compression. This can lead to what we term tardy ulnar nerve palsy, meaning ulnar nerve problems that develop gradually over time due to this ongoing mechanical stress from the deformity. This sort of issue can also arise as a late consequence of previous injuries, like supracondylar fractures near the elbow or lateral condyle fractures that haven't healed perfectly. And then there are rarer anatomical variations that can play a role. Things like unusual fibrous bands within the FCU muscle, an extra muscle some people have called the anconeus epitrochlearis, or maybe a thickened edge of the fascia of another forearm muscle, the flexor digitorum superficialis. All these can create subtle points of friction or direct compression for the nerve.
So it sounds like it's not always an internal anatomical issue then. What about external sources of compression or perhaps other associated medical conditions that can contribute to cubital tunnel syndrome?
Indeed, it's often a multifaceted problem. External factors and associated medical conditions definitely play a significant role in many cases. For instance, the aftermath of previous injuries around the elbow can be a major contributing cause. We see cases where fractures, perhaps, or situations where a fracture hasn't healed properly, what we call a non-union, especially of the medial epicondyle, can lead to chronic nerve irritation. Also, the formation of bone spurs, known medically as osteophytes, or even abnormal bone forming in the soft tissues around the joint, called heterotopic ossification, can physically press on the nerve. Even non-cancerous growths like tumors or ganglion cysts, those are harmless fluid-filled sacs if they happen to be located near the nerve's path, can cause direct compression. So, broadly speaking, any post-traumatic condition that leads to persistent swelling or alters the normal anatomy around the elbow can predispose the nerve to entrapment.
And associated conditions.
Yes, in terms of associated medical conditions, we frequently observe cubital tunnel syndrome in patients who have pre-existing elbow deformities, like that cubitus varus or valgus, where the elbow angles abnormally inward or outward. Conditions like medial epicondylitis, which most people know as golfer's elbow, can also be linked, perhaps due to associated inflammation. Additionally, the scar tissue and altered mechanics that can result from previous burns around the elbow, or even from surgical procedures like an elbow contracture release, can affect the space and the way the ulnar nerve moves, making it more vulnerable to compression. Essentially, all these conditions can create a less hospitable environment for the nerve to function smoothly.
That's a truly comprehensive overview of the anatomy and the wide range of causes. Now let's turn to who is actually affected by this condition most often. What does the epidemiology tell us about its prevalence and demographics? Who tends to get cubital tunnel syndrome, and are there any clear patterns or reasons why?
Well, cubital tunnel syndrome is surprisingly common, actually. Current estimates suggest it affects approximately 30 out of every 100,000 people annually. This makes it the second most common nerve compression syndrome in the entire upper extremity, right behind the much more widely known carpal tunnel syndrome, which occurs at the wrist.
Second most common, wow.
Yes. When we look at the demographics, we generally tend to see males affected more commonly than females. Although, interestingly, females who do develop it often present with symptoms at an earlier age than males typically do. The overall incidence for both sexes generally tends to increase with age. This suggests there might be a cumulative effect at play, perhaps years of minor wear and tear, or maybe just age-related changes in the tissues and anatomy around the elbow that gradually increase the nerve's vulnerability over time.
So beyond the inherent anatomy or the effects of aging, what are the common triggers and contributing factors in our daily lives or occupations that put people at higher risk? We hear a lot about phone use, for example, but what else should we be mindful of?
Daily habits and occupational factors are indeed huge contributors, you're right. Prolonged or sustained elbow flexion is probably the primary culprit for many people. Think of any activity where your elbow stays bent for a long time. Holding a mobile phone to your ear for extended conversations, reading with your elbows tucked in tightly, or spending hours at a desk where your elbows are acutely flexed, maybe resting on an armrest. These positions directly compress and stretch the ulnar nerve, putting it under considerable stress over time. Similarly, frequently resting the inner part of your elbow directly on hard surfaces like the edge of a desk or a firm chair armrest applies direct pressure to the nerve and can definitely irritate it.
Makes sense. What about repetitive movements?
Absolutely. Repetitive strain from activities involving frequent arm movements or sustained elbow flexion is another major factor. This is very common in jobs that involve a lot of typing or assembly line work, certain types of manual labor, or even specific sports that involve repetitive throwing actions or sustained gripping with the elbow bent. Direct trauma to the elbow, like fractures or dislocations, is another clear risk factor, as it can cause immediate swelling or long-term structural damage that compromises the nerve space. We also know there can be a genetic component. Some individuals are simply born with a naturally narrower cubital tunnel, making them inherently more susceptible from the start.
And pre-existing conditions.
Yes, certain pre-existing medical conditions can significantly increase the risk or worsen symptoms, often by affecting overall nerve health or increasing systemic inflammation. Diabetes is a very significant risk factor here. Maintaining good blood sugar control is absolutely crucial, not just for general health, but specifically for preventing nerve issues like this. Thyroid disorders and various forms of arthritis can also contribute. And often overlooked are lifestyle factors like poor posture, which can affect the whole arm's mechanics, and notably, sleeping with your elbows bent tightly, which is a very common trigger for nighttime symptoms. There's also emerging research identifying obesity as a potential risk factor, suggesting that maintaining a healthy weight might play a role in prevention. But it's worth remembering, despite all these known factors, in a significant number of cases, we actually can't pinpoint a precise cause. We term these idiopathic cases.
That's incredibly helpful for understanding the really broad spectrum of risk factors we might encounter in our daily lives. So once someone is affected, what are the telltale signs and symptoms? How do people typically recognize cubital tunnel syndrome, maybe starting from those initial tingles through to the more progressive, potentially severe indicators?
Okay, so the initial symptoms are typically those familiar pins and needles or numbness sensations, what we call paresthesias. These are usually felt quite specifically in the small finger, the ulnar half of the ring finger, that's the side closest to the little finger, and sometimes extending across the back of the hand on that same ulnar side. Patients also often describe a sort of dull ache or discomfort along the inner aspect of the elbow, which can sometimes radiate down into the forearm and even the hand.
And certain activities make it worse.
Definitely. These symptoms are almost always exacerbated or made worse by activities that involve that excessive or prolonged elbow flexion. Holding a mobile phone for a long time is a classic example. Also, repetitive occupational or athletic activities that require sustained elbow bending and maybe re-outward stress on the joint, what we call valgus stress. Night symptoms are particularly common, often because people unknowingly sleep with their arms acutely bent, compressing the nerve for hours on end without realizing it.
Okay, so that's the start. What happens as it progresses?
Well, as the condition progresses, if it's not managed, the symptoms can become more severe and start to indicate increasing nerve damage. You might begin to notice actual measurable weakness. This could manifest as difficulty gripping objects firmly or trouble manipulating small items, leading to clumsiness or a tendency to drop things. This happens because the muscles that control fine movements in your hand, particularly the small intrinsic muscles and those responsible for flexing the knuckles of your fingers and also key muscles for pinch grip strength, are supplied by the ulnar nerve. You can actually lose up to 70% of your pinch strength in severe cases.
70%? Wow.
Yes, it's significant. Coordination issues also become more apparent. Making fine motor skills, things like typing accurately, doing up buttons on a shirt, maybe playing a musical instrument, incredibly challenging and frustrating. Then, in more severe and prolonged cases, we can even start to observe muscle atrophy. This is a noticeable loss of muscle bulk and strength. You might see it particularly in the small muscles between the bones of the hand, interossae, the fleshy mound at the base of the little finger, the hypothea muscles, and the web space between your thumb and index finger. And this is a critical warning sign. Once significant muscle wasting has occurred, it's generally irreversible even with successful surgery.
That's a sobering point.
It is. Patients might also report persistent pain even when the elbow is seemingly at rest, and clinically we might find a reduction in deep tendon reflexes in the hand or forearm. And in very severe chronic cases, you might even see a characteristic clawing posture develop in the ring and small fingers, where the middle and end joints remain persistently bent because the small muscles aren't working properly.
Those progressive symptoms sound quite alarming, particularly the potentially irreversible muscle wasting. What specific clinical signs do you, as a surgeon, look for during a physical examination to help confirm the diagnosis? What would you observe or test for?
Right. When we examine a patient suspected of having cubital tunnel syndrome, we look for several specific clinical signs that point directly towards ulnar nerve involvement at the elbow. First, just by careful inspection and palpation looking and feeling, we'd look for those visible signs of muscle atrophy we just discussed. For instance, a noticeable hollowing in the spaces between the bones on the back of the hand, or reduced muscle bulk at the base of the little finger. We'd also observe for that clawing posture of the ring and small fingers if the condition is advanced. A key observation during movement is to watch as the patient actively flexes and extends their elbow. We look to see if the ulnar nerve visibly or palpably slips out of its groove behind the medial epicondyle. This is called ulnar nerve subluxation, and it can be a sign of instability.
Okay, so observation first, then testing.
Exactly. We then carefully test sensation, usually with light touch or pinprick, to see if there's decreased feeling specifically in the small finger and the ulnar half of the ring finger distribution. For motor function, we specifically look for signs of weakness in the muscles supplied uniquely by the ulnar nerve in the hand. A classic test is the Froment sign. We ask the patient to hold a piece of paper firmly between their thumb and the side of their index finger, like holding a key. If the ulnar interhated thumb adductor muscle is weak, then compensate by strongly bending the end joint of their thumb, using a different nerve's muscle. That bending is the positive Froment sign.
I see.
Another is the Wartenberg sign. This is where the small finger remains persistently abducted, or sticking out away from the ring finger, even when the patient tries to bring all their fingers close together. This signals weakness in a specific small hand muscle, the third palmar interosseous. We might also look for Massa's sign, which is a flattening of the hand's arch, or Pollock's sign, an inability to flex the end joints of the ring and little fingers.
And what about provocative tests, making the symptoms appear?
Yes, we also perform specific provocative tests to see if we can reproduce the patient's typical symptoms. The Tenel sign involves gently tapping directly over the cubital tunnel at the elbow. If this reproduces that tingling or electric shock sensation down into the ulnar fingers, it's considered positive. Another very common test is the elbow flexion test. Here, we ask the patient to simply hold their elbow in a fully flexed position, often with the wrist extended too, for about 60 seconds. If this reproduces their numbness or tingling, it's a strong indicator of compression in that position. And, naturally, applying direct, gentle pressure over the cubital tunnel itself might also exacerbate the symptoms, providing further confirmation during the examination.
That's a very detailed picture of the hands-on diagnostic process. So once these signs are observed and the clinical picture starts to form, what's the broader diagnostic journey typically like? Are there specific tests, maybe imaging or electrical tests, that not only confirm cubital tunnel syndrome, but also help rule out other conditions that might mimic it?
Yes, the diagnostic journey really starts, as I've outlined, with that thorough clinical evaluation, the detailed medical history, understanding the symptom's location, nature, and triggers, followed by the physical examination assessing sensation, muscle power, and those specific clinical signs like a positive Tinel's or elbow flexion test. Now, to confirm the diagnosis objectively, and importantly, to assess the severity of nerve damage, we often rely on specific diagnostic tests. Electromyography, or EMG, and nerve conduction studies, known as NCS, are really crucial here. You can think of these tests as providing an electrical diagnostic map for your nerves and muscles. Nerve conduction studies measure how quickly electrical signals travel along the ulnar nerve, specifically as it crosses the elbow, and also the strength or amplitude of those signals. If the nerve is significantly compressed at the elbow, the electrical signal will slow down markedly at that point compared to other segments of the nerve, or the strength of the signal might be reduced. A conduction velocity dropping below about 50 meters per second across the elbow segment, often coupled with low amplitudes of the nerve signals, is a key diagnostic threshold.
Right, the electrical tests.
Exactly. However, it's important for patients and clinicians to know that these tests can sometimes produce false negative results. This means a seemingly normal test doesn't entirely rule out the condition if the clinical signs and symptoms are strongly suggestive. They are helpful, but not infallible. We also typically use X-rays of the elbow, not really to diagnose the nerve issue directly, but primarily to look for and rule out other underlying bone or joint conditions like fractures, bone spurs, or significant arthritis that might be contributing to the elbow symptoms or mimicking the nerve pain.
And why is early diagnosis so important?
The importance of early diagnosis really cannot be overstated in cubital tunnel syndrome. Recognizing and diagnosing it promptly is absolutely crucial. It allows us to intervene, often with those simpler conservative measures, before potentially irreversible nerve damage, like that muscle atrophy, occurs. And it significantly improves the likelihood of achieving a successful and effective treatment outcome, minimizing long-term disability.
It sounds like there are quite a few conditions that can present with similar nerve-related issues in the arm or hand. How do you differentiate cubital tunnel syndrome from other conditions with overlapping symptoms, say carpal tunnel syndrome, which many people have heard of, or perhaps ulnar tunnel syndrome at the wrist, or even nerve root compression starting up in the neck?
Yes, differentiating cubital tunnel syndrome from other nerve compression conditions is indeed vital for ensuring an accurate diagnosis and, consequently, selecting the most appropriate treatment plan. Let's start with carpal tunnel syndrome, as it's probably the most common point of confusion for patients. The key difference lies in which nerve is involved and where the compression is happening. Carpal tunnel syndrome involves the median nerve being compressed at the wrist. Its symptoms, the tingling, numbness, sometimes pain, typically affect the thumb, index finger, middle finger, and only the radial half of the ring finger, the side closest to your thumb. Cubital tunnel syndrome, in contrast, involves the ulnar nerve being compressed up at the elbow, and its symptoms are distinct, primarily affecting the small finger and the ulnar half of the ring finger. So the specific pattern of finger involvement is usually a major clue.
Okay, different fingers, different nerve, different location. What about ulnar tunnel syndrome? That's similar.
It does sound similar because it also involves the ulnar nerve, but the compression site is different. Ulnar tunnel syndrome occurs when the ulnar nerve is compressed down at the wrist, in a place called Guillen's canal, not up at the elbow. The differentiators here can be subtle but are important. With cubital tunnel syndrome at the elbow, you might observe less severe finger clawing compared to some severe ulnar tunnel cases. Critically, in cubital tunnel, there will usually be a sensory deficit on the back, dorsal aspect of the hand on the ulnar side, because the nerve branch supplying that area comes off above the wrist. Also, cubital tunnel syndrome can affect the ulnar innervated extrinsic muscles, like some of the deep finger flexors in the forearm, which ulnar tunnel syndrome generally doesn't touch. And of course, clinically, the tunnel sign will be positive at the elbow, not the wrist, and the elbow flexion test will reproduce symptoms. With ulnar tunnel syndrome, sensation on the back of the hand is usually normal, and the power of the SCU muscle and the deep flexors to the little finger remains normal.
Right, so location of signs and specific sensory motor patterns are key there. What about issues starting in the neck, like a pinched nerve?
Yes, distinguishing it from cervical radiculopathy, particularly C8 radiculopathy, which means nerve root compression originating from the C8 nerve root in the neck, is also very important, as symptoms can overlap. In cubital tunnel syndrome, as we've said, you get the characteristic tingling and numbness in the ring, and little fingers, and maybe weakness in specific hand muscles or deep finger flexors. With C8 radiculopathy, while you might get some similar sensory changes, a key differentiator is often that the symptoms might actually improve when the shoulder is abducted, meaning lifting the arm out to the side and maybe putting the hand on the head, the shoulder abduction relief sign. This isn't typically the case with cubital tunnel syndrome. Neck pain or restricted neck movement might also point towards a cervical origin. And we always have to consider other differential diagnoses too. Things like thoracic outlet syndrome can cause arm tingling, but symptoms are often worse with overhead arm positions. Issues stemming directly from the cervical spine or C-spine, often present with accompanying neck and shoulder pain that clearly radiates down the arm. A T1 nerve root lesion, another type of nerve compression higher up, can cause weakness in the thenar muscles at the base of the thumb and maybe decreased sensation in the inner forearm. And even rarer conditions like a Pancoast tumor, a type of lung cancer affecting nerves at the top of the chest, or systemic illnesses, diabetes, alcoholism, hypothyroidism, certain vitamin deficiencies can manifest with similar neuropathic symptoms. This complex diagnostic landscape really underscores why a thorough clinical evaluation, often supplemented by those electrical tests or sometimes imaging, is so essential to pinpoint the correct underlying cause.
That's incredibly insightful. Knowing just how complex the diagnostic picture can be truly highlights the importance of getting that expert evaluation. Now, let's pivot towards treatment. For those listeners experiencing cubital tunnel syndrome, what are the first lines of attack? What are the main conservative, non-operative treatment options? When is this approach typically indicated, and what does it actually involve day to day?
Right. Non-operative management is indeed the crucial first line of treatment, especially for individuals experiencing mild to moderate symptoms. And very importantly, it's the standard approach when there's no clinical evidence of significant motor denervation. yet meaning the nerve hasn't suffered damage leading to obvious muscle weakness or wasting. The primary goals here are quite straightforward. Alleviate the symptoms, prevent the condition from getting any worse, and allow the nerve a chance to recover without needing more invasive procedures.
So what are the main strategies?
The core strategies involve several practical adjustments and therapies. First and foremost is activity modification. This really means actively identifying and then consciously avoiding the habits or postures that put stress on your ulnar nerve at the elbow. For example, if you spend a lot of time on your mobile phone, switch to using a hands-free device or speakerphone, or alternate ears frequently to avoid that prolonged elbow bending. If you work at a desk, make a real effort to avoid resting the inner part of your elbow on hard surfaces or armrests. Even simple changes, like making sure you don't drive for long periods with your arm resting on an open car window ledge, can significantly reduce nerve irritation.
Okay, so being mindful of posture and pressure.
Exactly. Another absolutely critical component, particularly for night symptoms, is nighttime elbow extension splinting. Many people unknowingly make their symptoms much worse by sleeping with their elbows bent tightly, which compresses the nerve for hours on end. So we recommend bracing the elbow in a position of relative extension, usually around 45 degrees of flexion, so not dead straight but quite open, with the forearm in a neutral rotation specifically during sleep. This prevents that sustained acute flexion overnight. A very practical quick win for this, something anyone can try, is simply wrapping a thick towel loosely around a straight elbow, secured with tape, just enough to prevent full bending. Or even wearing a soft elbow pad backward can sometimes provide enough of a reminder.
That's a good tip. What about medications?
Medications can play a supportive role, but it's limited. Primarily, over-the-counter non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen, can help to reduce any associated swelling and alleviate some of the pain or discomfort around the nerve. However, it's crucial to note that steroid injections are generally not recommended or used for cubital tunnel syndrome, unlike for some other nerve compressions like carpal tunnel. There's a significantly higher risk of directly damaging the ulnar nerve with an injection in this very confined and superficial space at the elbow.
Right, no injections, usually.
Correct. And finally, but perhaps most importantly, is patient education. It's invaluable. When you, the patient, understand what's actually happening, what specific activities trigger your symptoms, and how these conservative strategies work, you're much more empowered to actively participate in your own recovery and make those necessary changes stick.
And what about physical therapy? Are there specific exercises that can help? I'm particularly interested in those nerve gliding techniques that you sometimes hear about for nerve entrapments.
Absolutely. Physical therapy, often delivered by a specialist hand therapist, can be a cornerstone of effective conservative management. And it really goes beyond just general strengthening exercises. It focuses initially on improving flexibility around the ulnar nerve pathway through gentle range of motion exercises for the elbow, wrist, and fingers. It might also include strengthening exercises for the muscles in the forearm and hand, not to bulk them up, but to improve overall function and provide better dynamic support around the nerve.
Okay, but the nerve glides.
Yes, the truly specific and often highly effective exercises for cubital tunnel syndrome are nerve gliding exercises, sometimes called nerve flossing or neuromobilization. These are not about building strength at all. They are designed to gently mobilize the ulnar nerve, encouraging it to slide smoothly through the cubital tunnel and other potential tight spots along its path. Imagine a long cord, like a brake cable on a bike, that's getting a bit stuck or irritated within its sheath. These exercises help it slide more freely, reducing friction and tension. This, in turn, can significantly alleviate those symptoms of tingling and numbness.
How do they work? Can you describe one?
Sure. We typically teach a sequence, but a common one, let's call it exercise A, involves starting with your arm extended straight out to your side, level with your shoulder, palm facing up towards the ceiling. Then tilt your wrist and fingers back as if you're signaling stop. From this starting position, you slowly and gently bend your elbow, bringing your hand towards your shoulder or ear, almost like you're trying to make a circle around your ear with your fingers. Keep your head facing forward in a neutral position throughout. You should feel a gentle stretch along the inner arm or forearm.
Okay, gently bending the elbow with the wrist back.
Exactly. And then exercise B is off of the reverse. From that bent position, with your hand near your ear and wrist still tilted back, you then slowly straighten your elbow again, moving your arm back out to the side, maintaining that wrist back position throughout the entire movement. The key with these is to perform them slowly and smoothly, maybe 3 to 5 repetitions at a time, several times a day. It's crucial not to push into sharp pain or hold the end position for too long. If you feel a strong pull or definite pain, you need to ease back. The goal is gentle, rhythmic movement, not aggressive stretching.
That makes sense. Gentle mobilization.
Precisely. And when patients consistently apply this combination of non-operative strategies, the activity modification, the night splinting, the nerve glides, we see successful resolution or significant improvement in approximately 50% of cases, maybe even more for very mild early presentations, which is a very encouraging outcome for a first-line approach.
That's genuinely encouraging for milder cases, knowing that these conservative options can be so effective half the time or more. But what happens when conservative care just isn't enough? Or perhaps if the symptoms are already quite severe when someone seeks help? When do surgical interventions become the necessary next step? And what are the primary surgical options available for cubital tunnel syndrome?
All right. When conservative measures, after a fair and consistent trial period, typically we say at least 3 months, sometimes longer, fail to provide significant or lasting relief, that's one major indication for considering surgery. Other key indications include the presence of clear, objective evidence of intrinsic muscle weakness or visible atrophy in the hand muscles supplied by the ulnar nerve, or if electrical testing shows signs of severe nerve compression or denervation, or indeed if there's a clinically obvious unstable ulnar nerve that consistently subluxates or slips out of its groove, causing symptoms with movement. In these situations, the overriding goal of surgery is to definitively decompress the nerve, give it more space, relieve the pressure, and crucially, prevent any further potentially irreversible nerve damage from occurring.
Okay, so what are the main surgical choices?
There are essentially 3 primary surgical options commonly performed, each with its own specific indications and nuances. The first, and often considered the most straightforward choice for many cases of mild to moderate compression, where the nerve is stable and the anatomy is relatively normal, is called in situ ulnar nerve decompression, sometimes just called a simple release.
In situ meaning in place.
Exactly. The nerve isn't moved. The mechanism here is relatively simple. The surgeon carefully cuts and divides the ligamentous structures forming the roof of the cubital tunnel, particularly Osborne's ligament and the fascia over the FCU muscle. This immediately increases the volume of the tunnel, effectively relieving the pressure on the nerve residing within it. Over time, new tissue heals across this divided ligament, maintaining the expanded space. This procedure is generally performed through a relatively small incision, maybe around 4 centimeters long, located on the inner side of the elbow. We focus specifically on releasing the known constricting bands. A crucial technical point is to avoid dissecting the nerve too much all the way around its circumference, as this can potentially damage its delicate blood supply or even make it hypermobile afterwards. This approach generally boasts good to excellent results, perhaps in 80–90% of appropriately selected cases, especially when symptoms were mainly intermittent and significant muscle denervation hadn't yet set in. However, it's important to reiterate that if significant muscle atrophy is already present before surgery, the prognosis for fully recovering that lost muscle strength is unfortunately much less favorable, regardless of the decompression.
Okay, so simple release is option 1. What if that's not deemed sufficient, or if the nerve is unstable? This is where I've heard of transposition procedures, which sounds like actually moving the nerve somewhere else.
Precisely. If an in situ release is thought to be insufficient, perhaps because the compression is very severe or extends over a longer segment, or if the nerve is clearly unstable and subluxating, or if there are significant structural issues like a bony deformity, severe scarring from previous trauma, or maybe a tumor affecting the nerve bed, then ulnar nerve anterior transposition is often the preferred surgical option. As the name suggests, this procedure involves physically moving the ulnar nerve from its original problematic position behind the medial epicondyle to a new, more protected location in front of it. The key mechanism here is twofold. Firstly, it prevents the nerve from getting stretched or caught on that bony ridge of the epicondyle every time the elbow is bent. Secondly, it effectively provides some functional lengthening of the nerve, maybe around 3 to 4 centimeters, which can reduce tension along its course.
So you actually reroute the nerve.
Yes. We carefully lift the nerve out of its groove, ensuring its blood supply is preserved as much as possible, and then reroute it to the front of the elbow. Transposition is specifically indicated, as I said, for cases where a simple release might have failed previously, when the ulnar nerve visibly or symptomatically subluxates, or in the presence of significant elbow deformities or abnormalities around the nerve's original bed. It's also often considered the procedure of choice for high-level throwing athletes, where maintaining nerve stability under stress is absolutely paramount. And some studies suggest improved outcomes with transposition for unstable nerves in the pediatric population too.
Are there different ways to do the transposition? Where exactly does the nerve end up?
Yes, there are a few different technical variations for where the nerve is placed anteriorly. After decompressing and carefully mobilizing the nerve, often excising the medial intermuscular septum proximally to prevent kinking, the nerve can be transposed. Subcutaneously, meaning it's placed just under the skin and the layer of subcutaneous fat lying on top of the forearm muscles. This is technically simpler, but might leave the nerve slightly more vulnerable to direct trauma. Intramuscularly, where a small trough or channel is created within the flexor pronator muscle mass originating from the medial epicondyle, and the nerve is tucked into this muscular bed. Or submuscularly, this is generally considered the most protective position, where the nerve is placed completely underneath the main flexor pronator muscle group. This requires surgically elevating these muscles from the bone, placing the nerve underneath them, and then securely reattaching the muscles over the nerve. This submuscular technique often requires a longer period of immobilization in a sling postoperatively, typically around 3 to 6 weeks, to allow the muscles to heal back down. While overall outcomes between in situ release and transposition techniques are often reported as similar in large studies, transposition does carry a slightly increased theoretical risk of inadvertently creating a new point of compression or kinking at the site where the nerve enters the muscle or fascia, although the actual recurrence rate after transposition is generally quite low.
Okay, that's clear. Release or transposition. Is there a third main surgical option, perhaps involving the bone itself?
Yes, there is a third primary surgical option, although perhaps used slightly less frequently now than the other two in some centers. This is medial epicondylectomy. This procedure involves surgically removing a portion of the medial epicondyle itself, that bony funny bone prominence, through a precise oblique cut in the bone, an osteotomy. The aim here is conceptually similar to transposition. By removing the bony ridge that the nerve has to pass behind, we prevent the nerve from getting caught, stretched, or compressed against it, especially when the elbow is bent. The nerve essentially then finds its own path slightly anteriorly without needing formal transposition.
So you remove part of the bone instead of moving the nerve.
Exactly. This approach is typically indicated for specific situations, such as patients with a clearly visible and symptomatic subluxating ulnar nerve where transposition might be technically difficult, or perhaps for very thin patients who may not have enough subcutaneous fatty tissue to provide adequate cushioning if the nerve were simply moved subcutaneously via transposition. It's also considered a good option for cases with significant valgus elbow deformity, or where there's a malunited fracture or other bony abnormality of the epicondyle that is directly irritating the nerve. However, medial epicondylectomy does have some potential disadvantages. It can lead to more noticeable scarring in some cases. Since the bony prominence is removed, it can sometimes make it uncomfortable or painful if the patient subsequently leans directly on that inner aspect of their elbow. There's also a potential risk, if not done carefully, of weakening the origin of the elbow's flexor muscles, which is why it's generally contraindicated or not recommended for high-demand athletes.
Crucially, during the procedure, the surgeon must work very carefully to preserve the underlying medial ulnar collateral ligament, MCL, which is deep and slightly lateral to the bone being removed, as this ligament is absolutely vital for the stability of the elbow joint. The technique involves carefully identifying, releasing, and protecting the ulnar nerve first, then gently lifting the common flexor origin muscles off the part of the epicondyle to be removed, and then precisely removing the necessary portion of the bone, ensuring a smooth contour is left behind.
Right, 3 distinct surgical approaches then. Once surgery has been performed, regardless of the specific technique, what's the typical post-operative care and recovery process like? And are there any common complications that patients should be aware of? Because it certainly sounds like a significant procedure no matter which approach is taken.
Indeed, recovery is a very significant part of the overall journey, and patience is often required. Post-operative care will vary slightly depending on the specific surgical technique used. For instance, as I mentioned, the submuscular transposition often requires a longer period of immobilization in a sling compared to a simple in situ release, which might only need a soft dressing and early movement. Generally speaking, while some patients might experience quite rapid improvement in their numbness and tingling symptoms, perhaps even within days or weeks. For many others, particularly if the nerve compression was severe or long-standing, it's a much more gradual process of recovery. Full recovery and realizing the maximum benefit from the surgery can take many months. Especially if symptoms were severe or had been present for a very long time before the operation, it might take up to 12 or even 18 months to fully appreciate the final results in terms of sensory return and potential motor recovery.
12 to 18 months, really.
Yes, nerve recovery is notoriously slow. It's fascinating, though. Studies using nerve conduction tests have shown that the actual speed and electrical signal transmission across the elbow, the conduction velocity, often returns to baseline levels within just 2 weeks of successful decompression surgery. And the more immediate nerve signal responses, the latencies, tend to improve even faster with early decompression. But translating that electrical improvement into noticeable functional improvement takes time. Physical therapy, usually with a specialist hand therapist, is almost always recommended following surgery. This helps patients regain their full range of motion in the elbow, wrist, and fingers, rebuild strength gradually, and importantly, includes exercises to ensure the nerve continues to glide properly in its newly decompressed environment, preventing scar tissue from restricting it again.
Okay, and potential complications.
As with any surgical procedure, patients should be aware of potential complications, although thankfully serious ones are relatively uncommon with experienced surgeons. These include the general surgical risks like infection at the incision site, wound healing problems, or perhaps a painful scar. Unfortunately, sometimes symptoms can persist despite technically successful surgery, or they might even recur later on. Recurrence can happen for various reasons. Perhaps the initial decompression was inadequate, meaning not quite enough space was created, or sometimes perineural scarring, that's excessive scar tissue forming around the nerve itself, can develop and tether the nerve. Or the nerve might get tethered at other points along its path that weren't fully addressed, like the intermuscular septum proximally, or the FCU fascia distally. It's worth noting that the rate of recurrence or need for revision surgery for cubital tunnel syndrome is actually thought to be slightly higher than what we typically see after carpal tunnel release surgery at the wrist. A more specific and often quite troublesome complication we sometimes encounter is the formation of an neuroma. This is essentially a painful, disorganized bundle of nerve tissue that you can form if a small sensory nerve branch in the area, usually a branch of the medial antebrachial cutaneous nerve, is inadvertently injured or cut during the surgery. This nerve crosses the typical surgical field about 3 centimeters below the elbow, and if a neuroma forms on it, it can cause persistent, often quite sharp or burning pain on the inner side of the elbow and forearm, which can be difficult to treat.
That's a very clear outline of the surgical landscape and what to expect during that lengthy recovery period. Given all these treatment pathways we've discussed, both conservative and surgical, what's the overall prognosis generally like for cubital tunnel syndrome? What can patients realistically expect in terms of recovery and long-term outcomes, and what factors seem to most influence whether someone had a good result or not?
The prognosis for cubital tunnel syndrome truly varies quite significantly from person to person, and it's definitely influenced by several key factors. Probably the most important factors are the severity of the nerve compression at the time treatment is initiated, and crucially, the duration of the symptoms before that treatment begins. As a general rule, patients who seek and receive appropriate treatment earlier in the course of the condition, especially before significant irreversible changes like muscle weakness or atrophy have set in, tend to have much better and faster recovery rates.
So timing is critical.
Absolutely critical. For surgical outcomes, the results are generally considered good to excellent in the long term, particularly for those individuals who had milder disease objectively and shorter symptom durations preoperatively. As I mentioned, patients often begin to notice improvements, sometimes starting as early as 1 month after surgery, with most achieving significant functional improvement within about 3 to 6 months. However, and this is an important point to manage expectations for severe or very prolonged cases where the nerve may have already suffered substantial damage, while surgery can still be very effective at alleviating pain and preventing further deterioration, it's less likely to completely reverse existing deficits, particularly muscle wasting or profound numbness. Full appreciation of any improvement in these more severe cases might, as we discussed, take that longer period of 12 to 18 months. It's important to set realistic expectations with patients in these situations. The primary goal might be to halt the progression of nerve damage and restore as much function as possible, rather than guaranteeing a complete return to a pre-symptom baseline. And while rare potential complications during surgery, like direct injury to the ulnar nerve itself, can unfortunately hinder recovery and might even necessitate further corrective intervention. But despite these considerations, when conservative treatments have clearly failed, surgery offers a vital and generally effective pathway to symptom resolution and a much improved quality of life for the majority of patients.
And what about the non-surgical outcomes?
For non-surgical outcomes, as we touched upon, many cases, especially those with milder intermittent symptoms, perhaps triggered by specific postures or mild trauma, often improve quite significantly with just patient education, activity modification, and maybe those nerve gliding exercises. This is why it's always our first line of defense and can be very successful. However, for more chronic or severe cases, If these conservative treatments don't provide adequate relief after a reasonable trial, then surgery often becomes a necessary next step to prevent ongoing, potentially permanent nerve damage.
The long term.
In the long term, it's important to counsel patients realistically, particularly those with severe preoperative findings. There is always the potential for incomplete recovery, especially if the nerve has suffered significant long-standing damage leading to axonal loss. Complete symptom resolution may not always be achievable in these advanced cases. But the main goal of any treatment approach we choose, whether it's conservative or surgical, is ultimately to restore as much function as possible, alleviate pain, and significantly improve the overall quality of life for individuals affected by this often debilitating condition. And achieving the best possible outcomes really relies on consistent communication between the patient and their healthcare providers, and diligent adherence to a comprehensive, tailored recovery plan.
So it really does sound like prevention is better than cure, if possible, especially given that potential for irreversible damage in severe cases. What proactive steps can people take, particularly our listeners who might be mid-senior professionals, often tied to desks or involved in repetitive tasks, to maintain good elbow health and minimize their risk of developing cubital tunnel syndrome in the first place?
Yes, prevention, especially for a condition so heavily influenced by daily habits and postures, is absolutely key, and there are several proactive steps people can take. Some general precautions include maintaining a healthy body weight. As we mentioned, emerging research identifies obesity as a potential risk factor, so broader positive lifestyle choices can certainly contribute to nerve health. For those in occupations requiring prolonged or repetitive elbow bending, think computer programmers, writers, graphic designers, accountants, even people who spend hours driving or on their phones consciously and regularly changing positions is paramount. Make it a habit to straighten your elbows frequently, stand up, move around. Avoid staying locked in one position for too long. Also, for our listeners who may have diabetes, diligent blood sugar management is a very important preventive measure, as diabetes is known to make peripheral nerves more vulnerable to compression injuries. And perhaps obviously but worth stating, try to avoid direct, repeated impacts or falls onto the inside of the elbow, that funny bone area.
That makes sense. What about those essential lifestyle tweaks and ergonomic adjustments for daily activities, especially for professionals who spend a significant amount of time working at a desk or computer?
Ergonomic adjustments in the workplace or home office are absolutely vital. Modifying your workstation setup to maintain a neutral, comfortable elbow position is paramount. This often means using ergonomic chairs that provide good back and arm support, encouraging good overall posture. Using an adjustable desk that allows you to easily alternate between sitting and standing can be very beneficial. The aim should always be for your elbows to be at a comfortable, slightly open angle when typing or using a mouse, ideally around 90 to 100 degrees, maybe slightly more open, rather than being acutely bent or compressed for prolonged periods.
Right, avoiding that tight bend.
Exactly. And consciously avoid positions or habits that exert direct pressure on the inner elbow nerve. This particularly includes avoiding leaning heavily on your inner elbows, especially on hard surfaces like desks or unforgiving armrests. If you find you have a tendency to do this, consider using soft elbow pads or cushions to distribute the pressure and protect the nerve. And that simple but highly effective change for managing potential night symptoms. Make a conscious effort to keep your elbow relatively straight while you sleep. As we discussed, you can achieve this relatively easily by loosely wrapping a towel around your straight elbow, secured gently, or by wearing a soft elbow pad backward just to prevent that inadvertent tight bending during the night.
So workstation setup and sleep position are key. What about exercise?
Yes. Beyond the ergonomic adjustments, incorporating a regular exercise regimen that focuses on maintaining flexibility, strength, and nerve mobility in the arm is highly beneficial for prevention, too. Simple stretching exercises, such as gentle wrist flexor and extensor stretches, aim to improve overall flexibility in the forearm muscles and tissues surrounding the ulnar nerve pathway. Strengthening exercises for the surrounding forearm, wrist, and hand muscles can enhance overall functional ability and potentially provide better dynamic support structures for the nerve during movement. And as we discussed in the context of treatment, regularly performing those specific nerve gliding exercises is particularly important for prevention too. They are designed to gently mobilize the ulnar nerve, promoting its smooth movement, enhancing its intrinsic blood flow, and potentially reducing the likelihood of restrictions or adhesions developing around the nerve due to sustained postures or repetitive movements. This combination of a regular targeted exercise routine, combined with thoughtful ergonomic adjustments to workstations and daily habits, can significantly promote overall arm and nerve health and substantially reduce the likelihood of developing cubital tunnel symptoms, or perhaps prevent mild symptoms from worsening.
And finally, just to round off the prevention aspect, what role does patient education and self-awareness play in all this? Because it really sounds like being aware of your own body and habits is a huge component of both prevention and early management.
Education, or perhaps better termed empowerment, truly plays a critical proactive role in both effective self-management and primary prevention. When individuals are empowered by really understanding their condition or potential risk factors, knowing their specific personal triggers like certain postures or activities, and recognizing the importance of adhering consistently to both treatment recommendations and preventive measures, they are far more likely to successfully integrate these crucial changes into their daily lives. When you understand why leaning on your elbow is problematic or why those specific nerve gliding exercises are beneficial, it fosters a sense of personal control and encourages proactive engagement in managing your own elbow and nerve health. It effectively turns passive reception of medical advice into active participation in maintaining your own long-term well-being.
That's a perfect summary of why understanding this matters. Thank you so much for that incredibly thorough and really actionable deep dive today. We've covered so much ground, from the intricate anatomy and subtle symptoms right through to the comprehensive treatment and prevention strategies. Now, just before we finish, let's do our lightning round, just a few quick, actionable pieces of advice based on everything we've discussed. So for someone who's just starting to feel those telltale tingles in their little and wing finger, what's one immediate, simple change they can make today?
Immediately, make a conscious effort to avoid prolonged or deep elbow flexion. If you're on a phone call, switch to hands-free or speaker. If you're at a desk, ensure your elbows aren't bent sharply for long periods. Straighten them out frequently. Take micro breaks.
Okay, avoid the bend. Are there any specific ergonomic tools or perhaps setups you'd particularly recommend to minimize risk, especially for our listeners who might be working from home or in hybrid models more often now?
Absolutely. An adjustable sit-stand desk is probably ideal, as it allows you to vary your posture and maintain your elbows at a more neutral 90-degree angle or slightly more open, whether sitting or standing. Also, if you do have a tendency to lean on hard surfaces, investing in some simple soft elbow pads to wear while working can make a surprising difference.
Good practical tips. Beyond the specific exercises we discussed, is there perhaps one particular book or maybe an online resource you'd generally point our listeners towards if they wanted to find more comprehensive, reliable information on this?
For broad, reliable, and well-vetted medical information for patients, I consistently recommend looking at the patient information sections of reputable professional orthopedic association websites. In the UK, organizations like the British Orthopedic Association or the British Society for Surgery of the Hand often have excellent resources. Internationally, the Ortho Info section provided by the American Academy of Orthopedic Surgeons, AOS, is also a very comprehensive and trustworthy source for patient-friendly information on conditions like cubital tunnel syndrome.
Excellent, thank you. And finally, what's a really quick win strategy specifically for managing those pesky night symptoms, which you mentioned are incredibly common?
The simplest and often the most immediately effective quick win for managing night symptoms is to physically prevent your elbow from bending deeply while you sleep. As we said, you can achieve this quite easily by loosely wrapping a thick bath towel around your relatively straight elbow and securing it gently with tape, just enough to act as a soft block. Or, sometimes simply wearing a standard soft elbow pad backward can provide enough of a physical reminder to stop you inadvertently curling up and compressing the nerve all night long.
Brilliant. Simple but effective. This has been an incredibly enlightening and valuable deep dive. Thank you so much again for sharing your invaluable insights and expertise with us today.
It's been my pleasure. It's certainly vital knowledge for maintaining everyday well-being and function.
And for you, our listeners, if you found this deep dive valuable, please do consider leaving us a rating or review and perhaps sharing it with your colleagues on LinkedIn or X. It genuinely helps us reach more professionals just like you. Thank you for joining us on the deep dive. And here's a final thought to leave you with. Consider how often we might overlook the subtle signals our body sends us, especially amidst the demands of our busy professional lives. What other seemingly minor discomforts could potentially be early signs of a larger yet manageable condition that, if addressed early, could dramatically improve your long-term quality of life and well-being?